Hello everyone, welcome to QXON. This is Dr. Parinita, your biochemistry teacher here at QXON. Today I'll be discussing about the cases related to acid-base balance. When I say acid-base balance, the first picture what comes to our mind is the acids and the bases in a chemistry lab. No, it is not that, but it is about the pH balance or the proper balance between the acids and the bases in the ECF is which is very crucial for the normal physiology of the body and also the cellular metabolism. Acid-base homeostasis is critical for more normal health, growth and the development. Many extracellular proteins like plasma proteins and membrane proteins of the body cells are very sensitive for their three-dimensional structures to the extracellular pH. Stringent mechanisms therefore exist to maintain the pH within very narrow limits. Outside the acceptable range of pH, proteins are denatured, causing enzymes and ion channels to malfunction. The acid-base disorders lead to wide variety of clinical problems: nausea, vomiting, electrolyte imbalance, increased susceptibility to cardiac arrhythmias, decreased catecholamine sensitivity, particularly in the cardiovascular system. And they can be osteoporosis, osteomalacia, recurrent nephrolithiasis, skeletal muscle atrophy, paresthesias, and coma. Body acidosis is a clinical state where there is an increase in acid or loss of bases. Alkalosis, in turn, is the increased accumulation of bases. Acid-base status of the body fluid is assessed by measurement of plasma pH and PCO2 concentration because of the important role of bicarbonate and carbonic acid system in the regulation of pH level, which we have already dealt in the theory part of the acid-base chapter. Now, when I say types of acidosis and alkalosis, since acidosis and alkalosis can result from the alteration of either bicarbonate level or PCO2 level, it is convenient to classify disturbances either as the metabolic or the respiratory disorders. If the alteration is due to change, decrease or increase in bicarbonate, the imbalance is known as a metabolic disorder, which can be either metabolic acidosis or the metabolic alkalosis, where the normal bicarbonate level is around 24 to 26 millimoles per liter. If the disturbance is due to change or increase or decrease in PCO2, the imbalance is known as respiratory disorder, where the normal PCO2 is 35 to 45 millimeters per mercury. So acidosis and alkalosis are exactly not the diseases, but rather are the result of a wide variety of disorders. The presence of acidosis or alkalosis provides an important clue about the serious metabolic problem. So coming to the individual disorders, that is metabolic acidosis, metabolic alkalosis, respiratory acidosis and the respiratory alkalosis. Let's see how the person with each of the disease or the condition presents with and what is the root cause for it and the lab investigations. First case, a 63-year-old woman with mild chronic kidney disease was admitted to the intensive care following a 9-day history of unexplained lethargy, breathlessness, and confusion. She had a long history of chronic back pain, and 2 weeks prior to the admission, she had been prescribed with paracetamol, that is 2 into 500 milligram tablets to be taken every 6 hours. Maximum recommended dose was given to her. On admission, the ABG analysis showed pH 7.03, bicarbonate level 6 millimoles per liter, base excess 22.6 millimoles per liter, anion gap 37 millimoles per liter, acetaminophen levels 430 microgram per ml. Plasma lactate was found to be normal. There were no ketone bodies detected in the urine, but 5-oxoproline was detected in the urine. So looking at the case, she is suffering from the kidney disease, but all of a sudden, After taking the tablets for the pain, which is maximum of the recommended dose, that is paracetamol, she comes with a history of lethargy, breathlessness, and confusion. This correlating with the ABG, pH is decreased. Let's just see the ABG analysis. Decrease in pH, decrease in the bicarbonate levels, increase in anion gap. So looking at these, we can come to a conclusion with a probable diagnosis of metabolic acidosis. So now what this metabolic acidosis is? It is nothing but the primary deficit of bicarbonate or depletion of bicarbonate due to excessive accumulation of the acids in the body. This is a most common acid-base disorder of the four. It is a condition which occurs when the body produces excessive quantities of acid or when the kidneys are not removing enough acid from the body. Blood pH is low, as in this case, which is 7.03, due to increased production of hydrogen ions by the body or due to inability of the body to form bicarbonate in the kidney. So there can be various causes. Now, based on the cause, we can have the diagnosis. I already said the metabolic acidosis or the acid-base disorders are not as such as a disease, but it is a condition due to various disorders, various other causes. Now, why this metabolic acidosis is seen in this patient? That is mainly due to the paracetamol toxicity, overdose of the paracetamol leading to high anion gap metabolic acidosis. Now, when I say this, there are various other causes of metabolic acidosis. So, what are the causes? Common causes of metabolic acidosis are diarrhea, diabetic ketoacidosis, starvation ketoacidosis, lactic acidosis, salicylate poisoning, etc. But for better understanding, they can be classified as high anion gap metabolic acidosis and normal anion gap metabolic acidosis based on the anion gap. So the high anion gap metabolic acidosis, mainly the anion gap of 15 to 20 millimoles per liter is an index of the condition which indicates the accumulation of acid ions in the case of metabolic acidosis. The common causes of high anion gap metabolic acidosis being ketoacidosis, that is diabetic ketoacidosis, starvation ketoacidosis, uremia, lactic acidosis, various toxins like ethylene glycol, methanol, as well as drugs like paracetamol, aspirin, metformin, etc. So these all end up with the high anion gap metabolic acidosis. When I say high anion, there should be normal anion gap metabolic acidosis too, where there is the anion gap is normal. Normal anion gap acidosis results from abnormal bicarbonate loss from the gut or the kidneys, like renal tubular acidosis. With a normal anion gap metabolic acidosis, the reduction in bicarbonate is mirrored by an increase in the chloride concentration. For this reason, a normal anion gap acidosis is sometimes also called as hyperchloremic acidosis. So what are the various causes? Acetazolamide use, renal tubular acidosis, diarrhea, ureterosigmoid fistula, pancreatic duodenal fistula, etc. These can be the causes of normal anion gap metabolic acidosis. Now, what is a biochemical basis in this particular case? As I said, the root cause for metabolic acidosis in this case is the paracetamol toxicity. What exactly happens over here? The paracetamol, which is also known as a acetaminophen or by its chemical name N-acetyl para-aminophenol. So the maximum recommended daily dose currently is 75 milligram per kg for children and 4 grams for adults. So paracetamol is primarily metabolized by conjugation in the liver to non-toxic water-soluble compounds which are eliminated out in the urine. In acute overdose or when the maximum daily dose is exceeded over a prolonged period of time, metabolism by conjugation becomes saturated and excess paracetamol is oxidatively metabolized by the cytochrome P450 enzymes to the hepatotoxic reactive metabolite, that is N-acetyl para-benzoquinone. Okay, now this what happens, this product what is formed, the metabolite is rapidly conjugated with glutathione and is then renally excreted, which can cause depletion of glutathione stores. There is also inhibition of synthesis of glutathione, which leads to accumulation of high levels of the organic acid, that is 5-oxoproline, or also called the pyroglutamic acid, right? So this accumulation of 5-oxoproline occurs in excessive intake of paracetamol, which is an intermediate of synthesis of glutathione, which is called the 5-oxoproline metabolic acidosis because of the accumulation of this 5-oxoproline, hence also called the 5-oxoproline metabolic acidosis. So this is the biochemical basis of the metabolic acidosis in the case of paracetamol toxicity. So now, looking at the findings, the lab investigations in the case, we have seen that pH is decreased due to decreased bicarbonate. Bicarbonate levels also is severely decreased, which is utilized to combat the increased acids. Anion gap again is high. Acetaminophen levels, that is 430, indicates paracetamol toxicity. So lactate level was normal excluding the lactic acidosis, and no urine ketone bodies were detected, which excludes the ketoacidosis. So all these findings together indicate that it is a case of high anion gap metabolic acidosis secondary to paracetamol poisoning. Now, when I say this, how does a patient of metabolic acidosis present? The metabolic acidosis case commonly presents with the Kussmaul's breathing, that is increased rate and depth of breathing. That is where this patient has come with a breathlessness. Also can be seen are uremia, renal failure, hypotension, chest pain, palpitations, severe anxiety due to hypoxia, decreased visual acuity, nausea, etc. When the pH falls below 7.2, acidosis is said to be dangerous. Coming to, before going into the investigations and the management of the case, we should know the compensatory mechanisms. That is, how does body try to combat this acid-base disturbance? The compensatory responses in general are always in the same direction as primary disturbances. For example, in case of metabolic disorders, compensatory mechanisms tend to decrease the carbonic acid. So in metabolic acidosis, we know that primary deficit is the decrease in bicarbonate levels. So the compensatory mechanism tend to decrease the carbonic acid level or the carbon dioxide level to keep the pH in normal. Primary compensation of metabolic acidosis is by the lungs, where there is hyperventilation, that is increase in rate and depth of respiratory rate occurs to expel more of the carbon dioxide to decrease the carbonic acid, thereby increasing the pH. The secondary compensation is by the renal system, which sets in within 2 to 4 days. What happens over here? There is increased excretion of hydrogen as titrable acidity, that is excretion of the hydrogen ions as acid phosphates. And also there is increase in excretion of ammonium ions. That is how the renal system tries to compensate the changes in the acid-base disturbance in the body. Coming to the management, we have to do certain investigations, that is blood sugar level, to rule out diabetic ketoacidosis, creatinine level, any renal disorders, serum electrolytes, arterial blood gas analysis to look for the various blood gas parameters, urine pH, and the urine ketone bodies. Coming to the management, the goals of the treatment are to treat mainly the underlying cause or the disorder, then improve the renal perfusion and increase acid secretion. As I mentioned, pH less than 7.2 or 7.1 is an emergency due to the risk of abnormal heart rhythms and may warrant treatment with IV bicarbonate. So this concludes the case of metabolic acidosis. In this particular case, it is due to the toxicity of the overdose of paracetamol.